In this video, we'll discuss about sickle cell anemia, various types of human globulins present in human body. In hemoglobin, there are 4 globulin chains. So, if all 4 globulin chain, always there are 2 alpha. Along with 2 alpha, if 2 beta chain present, it is known as hemoglobin A. If along with 2 alpha, 2 gamma chain is present, it is known as hemoglobin F. If along with 2 alpha, 2 delta are present, it is known as HbA2. The concentration of HbA 95 to 98 percentage. HbA is 95 to 98 percentage. It is major hemoglobin in human body. This one is the major human globulin. The concentration of HbF, hemoglobin F, is nearly 1 percentage or less than 1 percentage. The concentration of that hemoglobin A2 is less than 3.5 percentage. So these are the 3 type of hemoglobin along with their structure and their concentration in human body. So let's start with hemoglobinopathies. What is hemoglobinopathies? These hemoglobinopathies are the disorder of hemoglobin. This one is the disorder of hemoglobin. There are 2 type of hemoglobinopathies. One is qualitative disorder, another one is quantitative disorder. So what is the difference between qualitative and quantitative disorders? This qualitative, in this qualitative disorder, the quality of the hemoglobin, actually the globulin chain is not normal. So in this one, globulin chain is not normal, not good. So there is some structural abnormalities in the synthesis of globulin or hemoglobin. So here, what is the major problem? The structural abnormality in synthesis of hemoglobin. So here what will happen, the structure is not good, so there is some structural abnormality in the synthesis of globulin or hemoglobin. The abnormality is in the structure, but its amount and quantity is normal. Only structural changes, that amount and that quantity is normal. So the best example here, sickle cell syndrome. Now we want to discuss this one. Second type of hemoglobinopathies is quantitative. So in the second type, that quantitative, here the problem in that quantity, the amount, the quantity of the hemoglobin or globulin is reduced or decrease the synthesis, although structurally it is normal. This one structurally is normal, that quantity, the synthesis only decreasing. So the best example here, thalassemia. So here structural changes inside that quantity is normal. So it is called qualitative disorder. Quantitative disorder means inside the synthesis is reduced. Okay, the structural is normal. That name is called as quantitative disorder. Example, thalassemias. So there are 2 type of hemoglobinopathies, the qualitative and the quantitative. In qualitative, quality of globulin is not good. There is some structural problem, structural abnormality, and in quantitative, structural is normal, but it is reduced in that amount, quantity. So these are the 2 type of hemoglobinopathy. Here structural problem, here that amount, the globulin is reduced here. So now we want to discuss sickle syndrome. In this section we are going to discuss sickle syndrome, which is a type of qualitative hemoglobinopathy. This sickle cell syndrome, it is an autosomal recessive disorder. It is a autosomal recessive disorder. Here that abnormal hemoglobin is formed, which is known as hemoglobin S. So here that abnormal hemoglobin is formed here. That name is called as hemoglobin S, sickle hemoglobin. So there are three type of hemoglobin present in human adult body: HbA, HbA2 and HbF. But this HbS, that hemoglobin S, is not a normal hemoglobin. It is found only the person with sickle syndrome. So when that S is present, when that person having sickle syndrome, and it is a abnormal hemoglobin. This one is the abnormal hemoglobin structural changes. So in this patient, abnormal hemoglobin HbS present in the RBC, which leads to sickling of that RBC. So it leads to sickling of RBC. And now, what is the shape of normal RBC? It is biconcave. We know that biconcave because it's having hemoglobin A, the normal hemoglobin. But when the hemoglobin A is replaced by HbS, okay, the shape of that RBC changes from biconcave to sickle shape, and this phenomenon is known as sickling of RBC. So that is the sickle syndrome. There are three type of sickle syndrome. First one is heterozygous state of that hemoglobin. Yes, first one is heterozygous. There is one gene of HbA. So this heterozygous, there is one gene is HbA, that is normal, one gene HbA, and one gene HbS, that is abnormal. So it is known as AS. One is normal, one is abnormal. So AS, that is known as sickle cell trait. This is heterozygous condition, very mild. The second one name is called as homozygous condition, in which both the gene are HbS, both gene HbS, hemoglobin S. So there is total absence of HbA. The complete hemoglobin is S. Only, and this is known as, okay, see here only HbS, and this is known as sickle cell anemia. So here one gene A, hemoglobin A, another gene HbS, but here both gene are S. So this one name is called sickle cell anemia. The first one was sickle cell trait. This one is sickle cell anemia, and the third one is double heterozygous state. Double heterozygous state. It is this sickle D SD disease or sickle C disease, SC disease. So this third one is double heterozygous state, sickle C disease or sickle D disease. So these are the three forms. Next, now we want to discuss sickle cell anemia. It is a homozygous state of hemoglobin S in the red cell. Here there is one abnormal gene is inherited from each parent. So here one abnormal gene is inherited from each parent. It is an autosomal recessive condition. One of the abnormal gene from one of that parent, the other abnormal gene from other parent, both the parent have one abnormal gene, and both the parent have trait, but due to the a homozygous condition, the parent will have heterozygous condition, and the child having homozygous condition, that is that sickle cell anemia. Next, pathogenesis of sickle cell anemia. There is problem in the gene which is coding for beta chain of hemoglobin. In adult hemoglobin, the hemoglobin A are the 2 alpha chain and 2 beta chain. So in sickle cell anemia, there is no problem in alpha chain. Alpha chain are absolutely normal in the structure, but there is some problem in beta chain. So whereas the gene for beta chain, is present in chromosome number 11. Chromosome number 11. So on chromosome number 11 in the beta chain gene, there is a point mutation. Now what is that point mutation? See this diagram. In this diagram you can see first, this is the gene, this is the codon on the gene. If the beta this is the codon of beta chain. Now the gene of that beta chain which is present on chromosome number 11, this sequence presented on chromosome number 11, this is the that codon number 6. We know the chromosome various codon are present, which are triplet codon. This is the sixth number codon. This one is the sixth number codon. So sixth number codon is normally GAG, but here this adenine replaced by thiamine. Okay, so instead of GAG, it's GTG. So that is the point mutation. So mutation here, mutation point again. When it was GAG, it is coding for glutamic acid. This one code for glutamic acid. But now it is replaced by GTG. A replaced by T-thiamine. Adenine is replaced by thymidine. So adenine is replaced by this thymidine. Here adenine replaced by thymidine. Now it is coding for valine. It is coding for valine, not coding for glutamic acid. So this one was hemoglobin A is the normal hemoglobin, but now this one is hemoglobin S. So there is change in only one amino acid, the sixth amino acid, because there is 1 point mutation. So here 1 point is mutation at the sixth number codon. So at the sixth number codon, the exact mutation is that the adenine is replaced by thymidine. So at that sixth amino acid, it was normally glutamic acid, and now it replaced by valine. So it is replaced by one line. Because of this, the hemoglobin A is replaced by hemoglobin S. When it was hemoglobin A, it was dispersed throughout that RBC. So the shape of RBC was biconcave. It was normal circular by concave, but now the hemoglobin as it is not depressed, it was form elongated rod. So this one will form elongated rod. This one is the normal one, hemoglobin, then now it is the elongated rod. The shape of RBC changes from biconcave to sickle shape, and this is known as sickling. So this is the complete pathogenesis. At the sixth codon, the sixth position at the gene, there is point mutation which is known as missense mutation. So this is known as missense mutation, which is known as missense mutation, which leads to glutamic acid replacement. Okay, glutamic acid replacement and HbA replaced by HbS. So that is the complete pathogenesis. Now we have seen that consequence of sickling. What is happening that RBC, which is circular by biconcave, it is okay replaced by sickle shaped. Now what is the problem in that? It will leads to three problem in human body. Okay, three problems. First one, it leads to vasoacculation. Okay, first one is it leads to vasoacculations. So the consequence, there are three problems in human being. First one is vaso-occlusions of microcirculation. Second one is hemolytic anemia. Third one is increased MCHC, mean corpuscular hemoglobin concentration. So first one is occlusions of micro circulations. So it will leads to vaso-occlusions of that microcirculations on the capillaries. It will leads to increasing MCHC, that is mean corpuscular hemoglobin concentration. Uh, that RBC is biconcave. We know biconcave RBC is converted into here. Okay, it will converted into sickle cell shaped RBC. The shape is changing. So the sickle shaped RBC, the sickling takes place here only takes place when that hemoglobin is deoxygenated. During oxygenated state, this one is the normal. Okay, when it become deoxygenated, that time only it converted into sickling. That HbA is normal. HbA is always dispersed throughout that RBC. Okay, but inside here always dispersed throughout that RBC. It is like this inside normally presented like this. This RBC um, dispersed throughout, right? So HbS, what is the problem if that oxygenated? It is also dispersed like hemoglobin, but during deoxygenated state, now it form elongated rod. So normal hemoglobin, this one oxygenated state presented like that one, but during this deoxygenated state, deoxygenated state, it will form elongated rod. So it will form inside this one, elongation will happen. So elongated rod to accommodate through that elongated rod, RBC will become sickled shape. Okay, it changes to this shape. So during oxygenated state, that RBC circular only, but during deoxygenated state, it will converted into sickle shape. So this is the complete phenomenon. But throughout that procedure, throughout the day, oxygenated deoxygenated state takes place. So the shape of RBC change from circular to circular by concave to sickle, or and vice versa, again and again uh, repeatedly. But after multiple things happen, the cell membrane get damaged and that RBC become sickle shape permanently. So at that initial start of the disease, the sickling is reversible. The sickling is reversible on oxygenation. If you can the reverse the sickling, but later on the disease came the later on the cell membrane of that RBC is damaged permanently, sickling become permanent. At this point, understand, okay, here this damage, so this one is the permanent one. So during deoxygenation of that hemoglobin, during deoxygenation there is the polymerization of hemoglobin S, which leads to formation of rod, elongated rod like polymer to accumulate the shape of the RBC and distribute, and it is will become sickle shape, and this phenomenon is known as sickling. Now the problem is that sickle shape RBC. Now this problem is sickle cell RBC. So sickle cell RBC are very sticky. They are very abnormal sticky. They have high level of addition molecules on their surface. So they stick with each other and they will form clump. Okay, see here how it is presented. Here they will form clump. They stick with each other here. Okay, they stick with each other, they form clump, and because of the formation of clump they because occlusion in the microcirculation. See this diagram. In this diagram by concave RBC they don't stick, so here don't stick with each other, so they are flowing freely. Unrestricted blood flow is there when they are flowing inside the microcirculation, but when that RBC become sickle shape, okay, sickle shape during deoxygenated state like this, they are very sticky clump, they are sticking to each other. Okay, they sticking to each other, they are forming the club. They have high level of addition molecules, so they are blocking the microcirculation, and this is cause that vaso-occlusions. So this is how that vaso-occlusion takes place. So second condition, hemolytic anemia, with repeated episode of deoxygenation, sickling again and again. So during oxygenated state it is normal, but during oxygenated state it is sickle shape. Okay, this deoxygenated the time sickle shape. Due to a repeated episode of this again and again, the membrane damage permanently and RBC becomes sickle shape permanently. So when that abnormal sickle cell RBC passes through that this splenic schizocytes, the spleen recognize that is the abnormal RBC, and it causes phagocytosis of that spleen, and it causes the splenic accusations and phagocytis of that particular abnormal RBC. So that particular abnormal sickle shape RBC undergo hemolysis. Since the hemolysis takes in the spleen, not in that blood vessels, it is extravascular hemolysis, and it leads to hemolytic anemia. So that patient present with all the symptoms of this anemia like fatigue, lethargy, lack of energy. Here you can see this diagram, the splenic sinusoids inside which the sickle cell. Okay, this one is that splenic sinusoids inside the sickle shape. This one is the sickle shape RBC going, it will be secure start phagocytosized. Now the third problem, increasing MCHC. Problem is that when the membrane of sickle shaped RBC is damaged, so water will come out. So this one is damaged, so water molecules will come out. It will leads to intracellular dehydration, and it will leads to increase means that it increases mean corpuscular hemoglobin concentration. So all the water molecules will come out, it leads to increasing MCHC. When that RBC was by concave sickle shaped, it having adequate water, so that hemoglobin was dispersed throughout. But when RBC becomes sickle shaped, that membrane is damaged. Since that membrane is damaged, that RBC water leak out. Since that water leak out, there is a intracellular dehydration. Now the same amount of hemoglobin compact, okay, compact and lesser amount of water, so the concentration increase. That's why MCHC level increase. So these are the three problem which takes place in sickling or sickle cell anemia. This is hemoglobin A, this is GAG, and this adenine is replaced by thymidine, okay, thymidine. So GAG replaced by TG in the DNA. So hemoglobin A is replaced by hemoglobin S. When hemoglobin A is replaced by hemoglobin S, what will happen inside RBC? Okay, RBC initially, whenever there is oxygenated state, it back concave, but only. But whenever there is a deoxygenated state, it will converted into sickling. So sickling is a reversible initially, but sickle shape RBC are sticky. That's why they causes microvascular occlusions. But later on, the sickling become permanent because the cell membrane is damaged and it is permanent, and such sickle shaped RBC is removed and phagocytosis. Um, by that these sphenic sinusites, and it will leads to extravascular hemolysis. Though, so basically the two end result, okay, we have two end result. What are the two end result? Microvascular occlusion and anemia. These are the two end result. Next factors determining rate of sickling. First factor, amount of hemoglobin S and interaction with other hemoglobin. Second one is hemoglobin concentration of RBC. Third one is intracellular dehydration, decreasing pH, the length of the time red cell are exposed to low oxygen tension. So first one is amount of HBS and interaction with other hemoglobin. How much hemoglobin S present in human blood and interaction with others? Hemoglobin, either other hemoglobin are present or not. If they are present, what is the interaction of hemoglobin B as on their hemoglobin, or what that impact of other hemoglobin or hemoglobin S? So that is the thing. Now if there is a homozygous individual, that is HPS only. uh, so only hemoglobin B 100 percentage, okay, here hemoglobin B 100 percentage, hemoglobin as only, no other hemoglobin presented in homozygous condition. Homozygous condition, only hemoglobin only presented, not others. So here sickling takes place directly, only HPS is presented, so we can say directly proportional to HPS. Okay, so this hemoglobin is directly proportional to HPS. More HP means more sickling. We can understand that here. More hemoglobin only presented means more that sickling, HPS. Second, heterozygous condition. only 40 percentage of that hemoglobin, that hemoglobin only present at 40 percentage, as remaining 60 percentage hemoglobin are HbA. And this point is that HbA have an inhibitory effect of HbS. So more HbA, less is the sickling. Okay, only HbS presented means more sickling. Here HbA high means less amount of sickling only. So because here out of 100 only 40 percentage HbS, so sickling only will be 40 percentage, not 100 percentage. But in fetal hemoglobin, when that newborn is taking birth, when that newborn is taking blood in the hemoglobin, the predominant hemoglobin in that newborn is fetal HB for the hemoglobin for the first 6 months of life. After 6 months of life, that HbF is replaced by the adult HbA. HbA F also have inhibitory effect on HbS. So whenever a newborn with sickle cell anemia is born, in the first 6 months the newborn does not have any symptoms. This is the reason. So as soon as the newborn is taking place, so the hemoglobin in the newborn is HbS, and that HbF is have inhibitory effect on HbS. Sickling will not takes place and less takes place, so the newborn will not face any problem till 6 months of age. After 6 months, when the hemoglobin is replaced by adult hemoglobin, then that fetus or the newborn will have symptoms. The second factor determining sickling is Hb concentration of RBC, that is MCHC, mean corpuscular hemoglobin concentration. It is directly proportional to sickling. More is that MCHC is sickling, less MCHC is less sickling, and MCHC depends on that intracellular dehydration. So greater is the MCHC, greater is the sickling. MCHC more means sickling more. MCHC less means sickling is less. The third point, intracellular dehydration. How much water is present inside that RBC? If water is more inside that RBC, how much water presented inside that RBC? Water will be present, so the concentration of Hb will be less, MCHC will be less, sickling is less. But if that less water is present here, MCHC will more, the concentration will be more, the sickling will be more. So we understand that intracellular dehydration. Next point is that pH, that effect of pH of that blood less, that is acidic pH or acidosis is there in the blood. Acidosis causes reduced affinity of that hemoglobin for oxygen. So whenever the oxygen have reduced here affinity for oxygen, Hb have reduced affinity for that oxygen, that it leads to deoxygenated state of hemoglobin. Whenever the hemoglobin is deoxygenated, it will facilitate sickling. So basically acidosis is directly proportional to sickling. More is the acidosis, less is the pH, more is the sickling. This is the conclusion. The fifth one, the last factor, is the length of the time for which the low oxygen tension is exposed. The cell are exposed to low oxygen tension. So there are two type of organ in human body: organ which have fast blood flow and organ which have slow or sluggish blood flow. So all the organ which have slow and sluggish blood flow like bone, spleen, here the explore of that cell will be for longer time to that low oxygen tension is in deoxygenated state, because here the blood flow is very slow and sludges, so there is high chances of sickling in these organs. So faster in the blood flow, less is the sickling. Slower in the blood flow or sludges is the blood flow, more in the sickling. That is the point. Next, clinical features in the sickle cell anemia. There are two type of clinical feature: anemia and occlusive phenomena. In this, anemia occur when there is irreversible cycling takes place. So initially the cycling is irreversible, but after some time that membrane of RBC is permanently damaged, so RBC undergoes cycling permanently here. At that this point, when the cycling is permanent, there are sequestered and they are phagocytized by these splenic macrophages. So RBC is undergoing extra muscular hemolysis that will leads to anemia. So the patient present with the symptoms of anemia along with the jaundice along with the reticulocytosis. That second symptoms here: vaso-occlusive phenomena. Sickling is reversible, so on oxygenation it's normal, and deoxygenation sickling takes place. So when this sickling takes place during deoxygenated state, it is having high level of addition molecules on them, so they are very sticky. They just stick to each other, they just form their clump, they occlude the capillary. So vaso-occlusive symptoms are the most common manifestation in cell anemia in the initial stage. Next, name of that organ in which this vaso-occlusive phenomenon is taking place. What are the name of that organ? Most commonly, it takes place in bone. In bone, most commonly, it takes place in the bone. It can lead to hand-foot syndrome, especially in the digit. It's having end arteries, and whenever these end arteries are blocked by sticky clump on that sickle shape, they got inflamed. It's highly painful condition, and this is known as hand foot syndrome. Next one is femoral head. Their AVN, avascular necrosis, the cheekbone become prominent in the bone narrow, that maxillary bone in the cheekbone, it's trying to compensate by doing erythroid hyperplasia. So because of that compensation of marrow cavity is expanding, and it is leading to predominant cheekbone. So looking at the face, the child is having sickle cell anemia. The sometimes it occur with the skull bone along with the maxillary bone. It occur with the skull bone also. There is screw cut appearance. Okay, in this one it will have that screw cut appearance. The diagram attached here. So in the vertebra also same things happening, which leads to fish mouth appearance on the vertebra. Okay, fish mouth appearance. like this appearance. The shape of that vertebra, normally that shape like this, then it will change to that fish mouth. Apart from bone vaso-occlusions, phenomenon also takes place in the lungs, which leads to acute chest symptom, which is characterized by fever, cough, chest pain. Apart from which, varies that vaso-occlusion phenomenon in that brain, which leads to that seizure and stroke. There is vaso-occlusion phenomenon on skin, which leads to leg ulcer. Vaso-ocular phenomenon leads to penis aplastic crisis and spleen also. The spleen is causing phagocytosis of those RBC and causing extravascular hemolysis. So the size of that spleen increases. It is known as splenomegaly in that initial stage, but a later stage due to prolonged hypoxia, prolonged vaso-occlusive phenomenon, the spleen undergo acute this one is lead to autosplenectomy. Next, production against that falciparum malaria. There is production against now that a special property. All this person with the sickle cell anemia, there are protected against that malaria. So there is one advantage of having sickle cell anemia. Why? The person is protected against that malaria. We know malaria also have four types, that Plasmodium vivax, malaria, ovale, and falciparum. Out of four, it is protected against that falciparum. So what is the point here? All the patient with HPS, hemoglobin S, there are relatively protected against that falciparum malaria, because that malaria parasite consume oxygen. So here inside a RBC, here that parasite is present. So inside RBC there is parasite inside. Okay, it will consuming all the oxygen. This parasite blue color one, it consuming all the oxygen. So once it consume all that oxygen, it will causes deoxygenated state. In deoxygenated state, it will promote sickling. So this RBC converted into sickle shape. That RBC having the parasite, or it will get converted into sickle shape, because that parasite is consuming the oxygen. Now the sickle shape RBC will sequestered in that spleen. It will be phagocytes. And in the spleen, so much RBC is killed along with that RBC. Parasite Plasmodium present. That one also phagocytosis. So while that parasite load is down, they are protected against in this way. They are protected against that falciparum malaria. Next is screening test. Screening and confirmatory test. Screening test at that initial stage, the sickling is reversible, right? So just suppose we collected patient blood sample in the test tube. The blood samples of a patient in which you have suspects that patient having sickle cell anemia, but that patient is an oxygenated state. So okay, in this blood sample, oxygenated state means we cannot find out. Okay, so oxygenated state, you cannot find out sickling. So artificially we will create a condition in which there is a deoxygenated state created. So how do the that we will take that blood samples of that patient and mix it with that sodium metabisulfite. Okay, metabisulfite, it is a reducing agent. When you will mix that blood sample with the sodium metabisulfate, it will create that deoxygenated state. Okay, so now if that person is normal, don't have any sickling cell anemia, or so even deoxygenated state, the safe of RBC will remain circular only. um, the test is negative, but if that person having sickle cell anemia, on adding reducing agent, it will create deoxygenated state and undergo sickling, so on. So adding sodium metabisulfate just proper for peripheral blood smear, do microscopy. On microscope, if you find still the shape is circular, person is normal. Okay, circular, that person is normal. If the test is negative, but adding that sodium metabisulfate, if that shape is changing to sickle shape, so it is considered a sickle cell anemia, and this condition is positive. But this test is the screening test by adding reducing agent. Next one is diagnosis. First thing, look at that peripheral smear. In that peripheral smear, we find that sickle cell, target cell, and Howell Jolly bodies. So in this one, we can find out sickle cell, target cell, then that Howell jelly bodies. Next, ESR rate. Here ESR are reduced. Usually ESR rate increased in all anemia except sickle cell anemia, because no Rowlex formation. So here no Rowlex formation. And the most important diagnostic test, the confirmatory test, is that electrophoresis, dual electrophoresis. Okay, here we are using dual electrophoresis. So you can see here three electrophoresis band. Okay, this if it is normal person, this one is the normal person. You will find only one band. You will find only one band. That is hemoglobin A. This band is that hemoglobin A. But the person is sickle cell trait, have 50 percentage or 60 percentage. Um, Hemoglobin A, only 40 percentage only hemoglobin S. So it will find two band in hemoglobin in sickle cell trait, but that sickle cell anemia 100% of that HBS. So we can find whether we are finding one band or two band. If we are binding two band, of course it is a case of sickle cell trade. But if you are finding one band, you have to see that band HBA or HB. Yes, so that will decide that can differentiate sickle cell anemia from sickle cell trade. So here what we understand, the sickle cell anemia, it's one band. Okay, this one is one band. Sickle cell carrier or trade, it is two band. One band means sickle cell anemia, two band means sickle cell cancer or trade. How to differentiate that one band of HBS or HBA? Basically HBS move slowly towards anode. Okay, slow. HBS move slowly towards anode. HBA move faster towards anode. So this diagram also see here, HBA, it is moving fast towards that anode, and HBS is the slow one. So looking at that band, we can identify this is band HbA or HbS. If you are finding both, of course it is the carrier, it is trade. So that is all about sickle cell anemia.